Welcome everyone and happy Wednesday. Welcome to day 3 of the Humboldt Opioid Summit Series. We're very excited to have all of you here today in the webinar and joining us on Facebook Live. First of all, would like to thank our sponsors of this Summit Series, RxSafe Humboldt, Humboldt Community Health Trust, Aegis, the Humboldt IPA, the California AHEC, and the North Coast Clinics Network. We could not have brought this Summit Series to you without their valuable contributions. I'm Rosemary Denouden, and I am the chair of RxSafe Humboldt, and I will be moderating today's sessions. I've been the chair of this coalition since its inception, and I am honored and privileged to lead this work here in Humboldt County. Before we get started, we'd like to acknowledge that we are meeting virtually across many tribal lands and the lands of indigenous people. Those include the Talawa Dini, Yurok, Karuk, Hupa, Wiyot, and many rancherias, Elk Valley, the Resegini, Big Lagoon, Trinidad, Blue Lake, and Bear River. And for those of you that are joining us outside of Humboldt and Del Norte County, I encourage you to know what land you are on and to know what indigenous people's land you are living and working on. I'd also like to acknowledge that the opioid crisis has disproportionately affected many Native American communities, including the ones in Humboldt County. And that there are many others that are contributing to the work to stop the needless, inappropriate death rate due to opioids and the ripple effect due to the opioid epidemic. And we're actually going to hear from one of those communities today. Later today, we're going to hear from Kamau and the work that they're doing to impact their community. So I'd like to announce our daily winner. For those of you that have been joining, and we've told you that we're doing some incentive drawings. And so today's winner is Jessica. Can you tell us who has won today's prize?
Yeah, I'm delighted to announce that Lale Lawrence was today's winner for her full day long participation in actually yesterday's summit.
Congratulations. And if you attend all day today, you will be entered into today's drawing for a valuable prize, which we'll announce tomorrow. Just as a reminder, today's sessions are being recorded and they can be found archived on the RxSafe Humboldt website and on our YouTube channel. Over the last 2 days, we've talked about a lot of topics, some of which are sensitive and could be triggering for you and others. So we want to make sure that you have the support necessary if you are feeling like there's something you want to talk about. So we've made available the local behavioral health crisis line and the SAMHSA National Health Line. These are also available on our website at rxsafehumboldt.org. So please reach out if you do need support. I'd like to remind everyone of some ground rules before we get started. Today's session, we are going to have a little bit of Q&A like we've had in the past, but we ask that you exercise the step up and step back rule, that you give others time to talk and you respect what they're saying. Show kindness and respect to each other, and this is a safe and judgment-free zone. We encourage you to seek clarification if needed. We've made several ways to do that, including the chat and raise hand functionality, and that you respect each other's privacy. When you are not actively engaging in discussion, we ask that you keep yourself muted and your videos off. We've done that for you as you entered into this webinar, but we will be opening it up later for Q&A. So if you are not actively speaking, go ahead and mute yourself during that time. If you do have a question throughout the presentations, we encourage you to use the Q&A functionality or the raise hand functionality at the bottom of your screen. And if you need to reach any of us, feel free to use the chat box. For any questions about any of the content from today or how to get CME CEU, please reach out to us. Our contact information can be found on our website, again, at rxsafehumboldt.org. And again, we are offering CEU and CME credits. And in order to get those credits, we ask that you complete the evaluation for each day that you are attending. And we need those all submitted by the close of business on Friday. We will be sending you an email with that evaluation information. This can also be found on the RX Safe Humboldt website as well. It will be sent in the chat box at the end of the session today. So today, like we have been bringing over the last 2 days, we've got some really exciting content. As the planning committee thought about what we wanted to bring to everyone over the course of this summit, we felt that it was extremely important to have a robust, well-rounded presentation. For those of you that were with us all week, you'll recall that on Monday, we had a fantastic panel with folks with lived experiences. And for me, that was so important to put that front and center so that we could hear from those that have had experiencing with opioids or other substance abuse issues. And I can tell you that I was deeply moved and honored by their openness and transparency with what they have experienced. So I just want to say thank you to them, to the 3 individuals again. Yesterday, we heard from Dr. Candy Stockton, who talked to us about the science of addiction. And she really showcased the tendency, if we're not careful, to be biased in our approach and how we classify folks that have substance use struggles. And then that was followed by a fantastic presentation by Jessica Smith and Wes Harrison. And for those of you that were there, you'll recall that Wes gave us a little bit of homework. And I just want to remind all of you that were there and those that weren't that, you know, Wes challenged us to consider every interaction and to think about how we approach those interactions and the questions that we ask, and to make sure that we are not stigmatizing or triggering somebody in a way that's harmful, that we want to have every interaction to be the best that it can be. So I encourage all of you to take that homework and do it each and every day, to think about what you say prior to saying it in all of our interactions, both in a medical setting or a personal setting. So with that, we get to our presentations for today. First, we have Dr. Christina Lasich, and I'm really excited to hear about the work that Christina has been doing in the Western Sierra Medical Clinic. She has been committed to her community for many years to bring high quality healthcare and has developed a medication-assisted treatment program in her community. And I think she has a lot to offer all of us on the webinar today in solutions that we can bring to our practices. And in full transparency, Dr. Lasich is from the town that I was raised in and my parents live in still. And so I'm super grateful for the work that she is doing in her community and the fact that she can bring her expertise to us today. And then following Dr. Lasich, we have a presentation from Kamau, Dr. Eva Smith and Dagim. I'm gonna mispronounce his last name, I apologize. Taddesse are gonna talk to us about some really innovative work that they're doing out in Hoopa. So with that, I will turn it over to Dr. Lasich and we'll get started with today's presentation.
All right. All right. Welcome everybody to virtual Zoom land. Thank you all for joining us, and thank you RX Safe Humboldt for inviting me to be part of this great week of discussing opioid safety and harm reduction. And I just very much appreciate the opportunity to share my experience and some tips and some tricks of the trade. So I'm bringing to you a presentation about the strategies for tapering opioids and treating pain, because oftentimes our neighbors come to an intersection where pain and addiction collide. And I want to help you navigate through that intersection with two different acronyms. The first one is BRAVO. This was developed by Dr. Anna Lemke at Stanford, and BRAVO is an acronym to help you safely decrease opioid dosage. And then I developed an acronym called ENCORE to help with the treatment of pain and/or opioid use disorder. So let's begin our journey. Our learning objectives are to help you to learn about evaluating and categorizing pain, to learn about how to have conversations with your patients, and discover that pain and health and suffering are doorways to transformation. I have nothing to disclose, but much is to be revealed today. So how do we get here where we have an intersection of pain and opioid overdose deaths? We have a tale of two epidemics. Many of us will recall that there was a war declared on pain, where pain became the fifth vital sign. And doctors were being sued or disciplined because of poor pain control. And as a result, we had an exponential increase in opioid prescriptions. And here's a map of the nation, and the dark purple shows the highest number of prescriptions per capita. And you'll see that California was not the highest, but that doesn't mean we have not experienced an exponential increase in opioid overdose deaths. And we continue to experience that even now. Locally, today I was on a phone call with our county discussing the significant rise in opioid overdose deaths this year, particularly related to fentanyl being laced in fake prescription drugs. And I'm sure many of you have heard of that as well. And so how are we to stop both the epidemic of chronic pain and opioid overdose deaths? Well, we have BRAVO, this acronym to help you safely decrease opioid dosage in your patient population. So let's start with B, broaching the topic. Now imagine you coming into an exam room with a patient that you've never met, and this patient might be on a high amount of opioids, a high MME, and maybe even taking benzodiazepines as well. And it makes you uncomfortable as a practitioner. So our natural tendency is to want to jump into a conversation about, hey, this isn't safe. I really need to start a taper. And then you'll see the eyes widen on that patient that, again, you are meeting for the first time. You need to recognize that anytime we mention the word taper, it's going to create anxiety. So be empathetic initially. Come alongside them, meet them where they're at, and develop that therapeutic alliance before you start discussing words like taper or unsafe or we need to make a change, because you're going to lose them right at the beginning of that relationship. And then once it's time to make that broach that topic, you need to be careful and help them understand that you've taken everything into consideration. So the statement that you want to try to use is, you know, I've thought a lot about what you are experiencing. And that statement, I've thought a lot about you. You're already telling the patient that I care about where you're at, and I'm coming alongside you out of a place of concern, not out of a place of judgment. So broaching the topic of opioid taper is something for all of us to be careful with and to make sure that the patient knows that you care first. So next, when it comes to discussing opioid tapers, you want to have a discussion about risks of opioid use. Now, patients already are experiencing some of those risks, such as hormonal imbalances, or constipation, or anxiety, or difficulty sleeping. So they know what they are experiencing, but they may not be associating it with their opioid use. And so having that conversation about risks and also having the conversation about benefits and weighing the two. Hey, I see that you're experiencing a lot of risks in relation to the opioids that you're using, and I'm not recognizing a lot of benefits. So let's have a conversation about what benefits you are experiencing. Evaluating the side effects of the opioids, including opioids like methadone. Many patients don't know that methadone can affect the heart, and this is why we're getting an EKG. When they start recognizing those risks, then they start to think twice about being on the opioid dosage that they're on, or maybe even start contemplating change. So risk is part of that conversation. And recognize that addiction does happen. The longer that somebody is on an opioid, the more likely that you're going to have subsequent addictive behavior. But know that that's not the same as physical dependence. And patients will often get that confused, the difference between physical dependence and addiction. So remember, physical dependence is really what's happening physiologically with the body that is dependent to that chemical. And that chemical could be opioids, it could be nicotine, it could be caffeine, it could be sugar. And once that chemical is suddenly discontinued, there might be some withdrawal symptoms, and that's physical dependence. That's not addiction. And it's important to have that conversation. And then, of course, addiction refers to behaviors, the 4 C's, loss of control, dysfunction in that person's life because they've lost control, compulsive use or constant cravings, or continued use despite consequences. So recognize that addiction happens, address it in terms of what the definitions are with the patient, and then be able to move forward with a plan for safety. The next letter of Bravo is velocity, but I'm going to skip that one right now because I think it's even more important, especially when you're seeing someone that has a chronic painful condition, to look at other treatments for chronic pain. How do you support Bravo, a opioid taper, in someone that has chronic pain without losing function, for example? If they're unable to get out of bed, you're losing function. If you're tapering and you lose that therapeutic alliance where they start screaming at you, or they lose hope and they start crying inconsolably. So You want to be able to support your opioid taper by asking for ENCORE and bring back the alternatives to opioids for the treatment of pain. So let's look at the ENCORE acronym. E stands for evaluating pain. And you have to be a detective. I've been treating painful conditions for over 20 years, and every pain is a little bit different. So you want to ask a lot of questions. What does the pain feel like? What makes it better? What makes it worse? Maybe it's worse in the morning or worse throughout the night and makes it difficult to sleep. Maybe the pain is sharp, it's stabbing, it's shooting. Where exactly is it located? And are there any abnormal sensations with it? Numbness, tingling, ringing in the ears, burning sensation. You want to ask a lot of questions. What time of day and what position makes it worse? The more that you can evaluate the pain from a standpoint of asking a lot of questions and really listening to what they're telling you, the more you're going to be able to focus your physical exam. And when I'm doing a physical exam, I'm not talking about, you know, a quick physical exam of very limited body part. I really talk about a full rotisserie exam. I have someone standing, sitting, lying supine, lying prone, a lot of different positions. In fact, I was teaching one of our residents the other day that sometimes if I'm examining a hip, I'll examine that hip in a seated position, and then sometimes I'll additionally examine it in a supine position because that gives me a little different or new information in different positions with the same joint. So a full rotisserie physical examination when you're evaluating the pain. And once you've evaluated the pain, then you can categorize it. And there's two categories of pain that I like to stick with. First is mechanical pain. And mechanical pain is based on position, activity, or function. Examples include knee and hip arthritis, shoulder tendonitis, neck pain. But my favorite example to illustrate mechanical pain is spinal stenosis. So spinal stenosis is a process that involves the posterior column of the spine, the back of the spine. So when someone is in an upright position, seated position, or walking, the back of the spine, the posterior column of the spine, where your facet joints are, where your nerve roots are under more pressure or stress. And that is a mechanical pain. So when someone is leaning on a shopping cart, when they have spinal stenosis, they feel less pain because you've relieved the mechanics that's driving the pain. You have forwardly flexed that spine away from the posterior column, away from the facet joints, away from the nerve roots, and you've put more pressure on the front of the spine, and that helps to relieve some of the pain. So people with lumbar spinal stenosis, they almost always feel better when they're leaning on a shopping cart. And that's a great example of mechanical pain. And if someone feels better leaning on a shopping cart, you have a solution right there in front of you. And that's an assistive device, such as a walking stick, a cane, or the W word that nobody likes to hear, a walker. There are other solutions to mechanical pain, such as body pillows when sleeping at night for sleep posture. And my favorite is a zero gravity chair. I'm wondering if any of you have a zero gravity chair. They're the best way to control spine pain without a prescription. And there's various types of zero gravity chairs at various price points. And they're available through our, internet, Amazon, for example. So let me tell you about my first experience with a zero gravity chair. It was 20 years ago. I had 2 disc herniations in my lumbar spine. I had 3 epidurals, and I've been through months of physical therapy. And then finally, my physical therapist told me, hey, you know, I would really want you to try a zero gravity chair to be in between the times when you're doing your exercise program. So I went to the store and I got in this chair and I literally cried. For the first time, I felt relief. And I'll tell you why there's relief in a zero gravity chair. The spine is supported almost parallel to the ground, and that eliminates the effects of gravity. The hips and the knees are flexed nearly at 90 degrees, which eliminates muscle tension on the spine. And then the legs are fully supported, eliminating the lever arm forces or the pressure that the legs exert on the lower back. So a zero gravity chair is a great way to eliminate some of that mechanical spine pain that exists, and it can be used throughout the day. In fact, there is a patio version that's portable that people can take to job sites or camping or use outside. So start talking about that solution with your patients that have mechanical spine pain. So a category of pain, of course, is neuropathic pain. So neuropathic pain is different than mechanical pain. It's driven by our sensitive nervous system, our alarm system. And I talk to patients about our alarm system that becomes very sensitive to movement or touch. And examples include neuropathy like diabetic peripheral neuropathy, radiculitis, complex regional pain syndrome, fibromyalgia, and opioid-induced hyperalgesia. I have that in red because I want you to remember that for a little later. These are all examples of the alarm system becoming overly sensitive and causing a neuropathic pain. The hallmark of neuropathic pain is typically a burning sensation, a stinging sensation, a tingling or numbness associated with it. Those are all hallmarks of neuropathic pain. So what is a solution for neuropathic pain? A solution would be to help to desensitize the nervous system, to calm those nerves down, to reset the alarm system. And these are words that I use to explain to patients about what is happening to them so that they can understand this better. So how do we reset the alarm system? By neutralizing the nervous system. Neutralizing the nervous systems with medications to help calm those nerves down. And we have all used gabapentin, but unfortunately, gabapentin is not well tolerated in some patients. So you need to know about some of the alternatives to gabapentin. One of my favorites is zonisamide. That's another type of anticonvulsant, and that target dosage is 100 milligrams 3 times a day, and it can be used instead of gabapentin. There are other alternatives, topiramate, tiagabine, and pregabalin. The pregabalin I use as kind of a last resort because the side effects of swelling can be quite dramatic, and I think some of you have probably seen that before. So know what your alternatives to gabapentin are. And then the next family of medications that can help neutralize the nervous system is the tricyclic medications. And we don't call these antidepressants anymore, really, because I don't think anybody's using them as antidepressants. They're really analgesics. Imipramine is a medication that can be used as an alternative to amitriptyline. Now, amitriptyline causes a lot of side effects of drowsiness, dry mouth, and can be somewhat dangerous in the elderly. So imipramine has less side effects than amitriptyline, and desipramine has even the least amount of side effects. So your target dose for tricyclics to be used for neuropathic pain is starting at 25 milligrams at bedtime, going up to 50 if needed, or 75. I never go over 75. You usually are going to find an effect between that range, and it's always just at bedtime. Not only does it help with people that have neuropathic pain, but it also helps people that have neuropathic pain that aren't sleeping very well. So it kind of has a dual purpose to not only improve pain control, but also to improve sleep. Another category of medications is muscle relaxants. Baclofen particularly can be useful for helping to neutralize the nervous system because it's not only a muscle relaxant, but an NMDA antagonist. And then buprenorphine, I want you to consider that for neutralizing the nervous system. Before I go on, I wanted to know if there's any questions. Remember to use your Q&A, or you can also raise a hand. I'm happy to answer questions as we go along here. So getting back to how can buprenorphine help to neutralize the nervous system? Remember, I said that opioid-induced hyperalgesia is a form of neuropathic pain. So what is opioid-induced hyperalgesia? Well, that is the nervous system has become sensitized because of a frequent cycle of withdrawals. And that's typically seen in someone that's taking short-acting medications like hydrocodone or oxycodone. And because of the frequent cycle of withdrawals, it sensitizes that nervous system, and then they develop what we call opioid-induced hyperalgesia, where that pain is getting worse and worse and worse and worse. So I consider buprenorphine a way to help neutralize the nervous system. Buprenorphine is an opioid with a long half-life. So it can take that patient off of the frequent cycle of withdrawals, that roller coaster of hydrocodone, the roller coaster of oxycodone, and it can put them on a merry-go-round of buprenorphine. It's more chemically stable in the brain because of that long half-life. So they're not going through that frequent cycle of withdrawals. That will stop that cycle from sensitizing the nervous system once they're on that merry-go-round. So why aren't more people using buprenorphine? Well, I think part of the problem is it's kind of a puzzle when it comes to starting buprenorphine without causing precipitated withdrawals. And I do not mention that word induction because most of us in the business, we don't use that word anymore because it's scary. We're just starting buprenorphine. You're just starting it. So how do you solve this puzzle? So starting buprenorphine, there's 4 different aspects to analyzing the puzzle in order to start it. First is the patient. Is the patient motivated? Are they able to follow directions? Are they pregnant or not? And not that pregnancy is a contraindication to buprenorphine, but you really need to know if they're pregnant or not because it allows you to have more cautious approach. Next, what type of opioids are they on that you are replacing with buprenorphine? Is it the short-acting medications like hydrocodone or oxycodone, or are they long-acting like methadone or the transdermal fentanyl patch? So with methadone, if you're converting someone from methadone over to buprenorphine for whatever reason you need to, maybe risk of methadone, for example, you want them to be off of the methadone for at least 48 hours to 72 hours. That's extremely important so that they have enough of that methadone to wash out. Sometimes I'll give them a bridge opioid like tramadol or hydrocodone to get them through that methadone-free period of time. And then it's a matter of timing, how long they've been opioid-free, because they need to be in a mild to moderate amount of withdrawals before the buprenorphine is started, and whether or not you're starting the buprenorphine at home or in the clinic. In the past, I started prescribing buprenorphine in 2008. I used to do office starting of the buprenorphine, but now I do strictly at home. And most of us that haven't the experience with buprenorphine, we just do it at home. We explain the opioid-free period of time. I'll typically say, stop that hydrocodone at 8 o'clock tomorrow morning, and then the following morning you start the buprenorphine, and it's really just that simple. Remember to have a conversation about the expectations of buprenorphine. People are not going to feel normal the first day. Remember, buprenorphine has to build up in the system. It takes us several days for it to reach steady state, around 4 to 5 days. And so if they understand that, then you're not going to get a call the next day and say, hey, how come this isn't working for me? And then yesterday, I had an interesting phone call with one of the physicians that works with me. And she had started buprenorphine on a patient that was using heroin, large doses, and also prescription drugs. And he was already on the 8 milligram buprenorphine 3 times a day and still having withdrawals. So she started it 4 times a day, increased it at 4 times a day. And I suggested to her to also add gabapentin. This helps to stabilize during that transition period because gabapentin helps to block that stress reaction in the brain that causes withdrawal symptoms. So gabapentin can be started at 300 milligrams at bedtime. For that patient that was already experiencing withdrawals, I suggested the gabapentin 300 milligrams 3 times a day to really help to settle that nervous system down, to eliminate some of the withdrawal symptoms. So you can use gabapentin for a temporary period of time to help during a transition to buprenorphine. Any questions about that?
This is Rosemary, Dr. Lasich. We do have a question that is asking if you can discuss spinal cord stimulators at some point.
Oh,
I'm
yeah.
not sure if that fits in somewhere in your presentation.
Actually, one of my cases in the case discussion period is a patient that has a spinal cord stimulator, and we can talk a little bit about that at that time.
Perfect.
Yeah, great. Any other questions?
And Dr. Lasich, this is Jessica Osborne. Just want to remind folks that they can also raise their hand and we can invite them to unmute themselves if they would like to ask in person instead of over the Q&A as well.
Great, thank you. All right, so there are other ways to help neutralize the nervous system. The nerves, they need to move well. They need to be able to glide and slide within our extremities. Sometimes patients are sensitizing the nervous system by stretching or hanging on the nerves. So use of arm rests can be important if you have someone that has cervical radicular pain because the cervical nerve roots can be stretched if the arms are not supported. Use of a recumbent stationary bike can stretch that sciatic nerve frequently, and then reaching for a phone or a mouse can stretch nerves and sensitize the nervous system. You can read a lot more about the sensitive nervous system and solutions to calming those the nervous system down in one of my favorite books by David Butler. He's a physiotherapist in Australia, and this is a wonderful book by David Butler about the sensitive nervous system, nerve mobilization techniques, and also examination techniques as well. And then the other book that I really love, and I'll mention it later, by David Butler, is Explain Pain, a fabulous book not only for patients but also healthcare professionals as well. So once you've evaluated the pain, you've neutralized the nervous system, sometimes you need to have a conversation, or sometimes you need to strengthen the core. And strengthening the core involves muscles in the proximal muscle groups like the rhomboids, the trapezius, the abdominal wall, the gluteal muscles. Those are all really important muscle groups for a variety of reasons, because so much of painful conditions is caused by poor core strength. For example, we all know about back and neck pain can be caused by poor core strength, but also thoracic outlet syndrome. Thoracic outlet syndrome historically used to be called drooping shoulder syndrome. And you can just imagine the shoulders kind of drooping down, pulling on those nerve roots and producing the symptoms of thoracic outlet. Even something as simple as foot pain can be caused by poor core strength. And you would ask, well, how could that be? Because the foot's so far away from the core. Well, if there's poor core strength around the hip, then the hip's not going to be very well aligned. That's going to go down to the knee. The knee won't be very well aligned, and that'll go all the way down to the foot. So core strength influences the entire body and produces a lot of painful conditions out there. My favorite way for evaluating core strength is having someone stand on one leg. That's a very important building block for being able to walk, because you're either on one leg or the other. And if you can't stand on one leg, you're not walking, you're wobbling. Best way to improve core strength, very simply, is with two items: the Swiss ball and the wobble board. These can be used in a living room. The physical therapist can teach people how to utilize them. There's great books for self-guided exercise program. You can do everything from sit-ups to push-ups to sitting on the ball to standing on the wobble board. This is a great way to improve core strength. So we've evaluated the pain, we've neutralized the nervous system, we've improved core strength in the patient that has a painful condition. But next, sometimes we have to open up a conversation. Opening up a conversation about expectations. Let's face it, our patients want to be pain-free, and they also want to be able to do things they used to be able to do them 20 years ago. That's not necessarily realistic, and we all know it. And when they're chasing an unrealistic expectation, that tends to drive the want or desire for more medications, because the thought is the more medications, the more likely I'm going to reach being pain-free. And to be honest, I usually do not ask the question about rate your pain on a scale from 0 to 10, because people just want to focus on 0. And I don't want to focus on 0. I'm very frank with patients and say, my goal is not to make you pain-free. My goal is to make you more functional, to take the edge off the pain enough so that you can do more with your life. It's not about these unrealistic expectations. So having that open conversation with the patient and asking the question, what are you able to do now with the opioids that you were not able to do before? That's a very important question. It's really about managing the benefits versus the risks. If they're not able to sleep better, if they're not returning to work, or not returning to hobbies of enjoyment or playing with the children or exercise, then what is the point of being on the opioids if there's no benefits? So the benefits really lie in this question. What are you able to do now with the use of opioids that you were not able to do before? Critical question in evaluating risks and benefits. And we want to help our patients to increase their activity level while decreasing their reliance on opioids. That's the whole goal. Increase the activity levels. while decreasing reliance on opioids. But how do we help them do that? Oftentimes we have to address that fear avoidance behavior. They're so fearful of moving or doing an activity that they'll avoid it. So addressing that fear avoidance behavior oftentimes is helping them to learn more about the problem. So let's take, for example, that spinal stenosis example that I gave you. So someone learns that, okay, now I understand the mechanics of that pain, that when I'm leaning on something like the shopping cart, like a cane, like a walker, that I'm able to do more because I've relieved the pressure on that back of my spine. So then they're more apt to be more active because they have a way to be active because they've learned more about the problem. Helping them to explore ways to move, such as instead of putting your purse on the floor, put the purse up on a chair so you don't have to bend over all the way to pick it up. Different ways to move, working with their body, exploring and nudging the edges of pain. Just instead of going 10 minutes that caused a flare up for 10 minutes of walking, go 5 minutes and then gradually increase it. Help them to stay positive, help them to make plans, and help them to remember that hurt does not always equal harm. If they go for a walk and they experience a flare up, it's not that there's more damage that was done. It's just that some of the tissues are a little more inflamed, that there's not damage. An example is if someone is wanting to train for a marathon, for example, and they go out for a run, a 10-mile run for the first time, well, they're going to be pretty darn sore, but that doesn't mean they've done any damage. So there's a difference. And I again reference that book, Explain Pain by David Butler, because the more that we can explain pain, the less fear there's going to be about it. And fear is one of the greatest amplifiers of pain. So it's an important conversation to have with our patients. So after we've had those conversations, we next want to look at restoring health. Now, pain is a doorway to transformation. I consider it a doorway to health transformation because pain is a signal that something needs to change. Just like hunger is a signal you need to eat, thirst is a signal you need to drink. Pain is often a signal that something needs to change, and that something is usually health. And pain can be a motivator for those changes. And most of us in healthcare are really good at being able to restore health. And many patients know things that they need to do to restore health, like quit smoking, do more exercise. But we're missing some key components. And one of them is vitamins and supplements. So vitamin D level absolutely has to be checked frequently. We are seeing single-digit vitamin D levels in our clinic, and it's no wonder people have a painful condition. No wonder why they're feeling tired, and it's associated with headaches. So checking and being aggressive with vitamin D. Typically, I target 60 for vitamin D, with the low normal of 30 being too low in my practice, and then I will usually supplement with either once weekly prescription vitamin D or once daily. Supplements like acetyl L-carnitine or alpha lipoic acid can be very helpful for treating a diabetic peripheral neuropathy. So there are vitamins and supplements that can be used. But even more importantly, and something that's often not discussed, is an anti-inflammatory diet. That is not my grocery cart. It used to be my grocery cart maybe 30 years ago, but not anymore. The anti-inflammatory diet is a concept that your body will be in a state of inflammation if you are constantly spiking your blood sugar. So blood sugar spikes promote pain and inflammation. So an anti-inflammatory diet is following the principle of lowering the glycemic load. So every food has a number associated with it. It's called the glycemic index. And that number represents how high the blood sugar will spike after eating that particular food. And the higher the number, the higher the blood sugar will spike. So bread, pasta, potato, high glycemic index. So in order to lower the glycemic load, you have to eliminate those foods that have a high glycemic index. It's much the same principle of someone that has a diabetes and needs to follow a diet. So some patients, when I explain the anti-inflammatory diet, they say, "Doc, how come nobody has explained this to me?" And I say, "I don't know. It's probably the most important way to control inflammation without a prescription." Everybody that I see is taking these anti-inflammatory medications and experiencing side effects to them when they really need to be getting into and following an anti-inflammatory diet. And one of my favorite examples for substitution is oatmeal. So we think that oatmeal is healthy, but not all oatmeal is created equal. So you have rolled oats, you have quick cooking oats. Those are easy for your body to digest. And if they're easy for the body to digest, it spikes your blood sugar. And anything that spikes your blood sugar is going to promote inflammation. But then you have the steel cut oat, which is the groat cut once, and you have the oat groat. Now those are harder for the body to digest, and so it doesn't spike the blood sugar. It has a lower glycemic index. So that simple substitution of oatmeal using steel cut oat instead of the rolled or quick cooking oats can lower the glycemic load for that particular meal. But then patients say, "Well, Doc, it takes too long to cook the steel cut oats. I don't have that much time." Simple solution: soak it overnight. Soak it overnight, and then you can just eat it raw in the morning. It's already ready. So teaching nutrition alongside cooking skills can be extremely important. And I want to call to your attention a conference coming up. Harvard does a conference every year called Healthy Kitchens, Healthy Lives. It's coming up in February. The registration is open. It's virtual next year. So everybody that's interested in learning more about nutrition and cooking techniques, check it out. It's probably the best conference I've ever attended. Any questions before we move on?
So Dr. Lasich, I am seeing one in the chat, and I don't know if you care to address this here or later, but Philip Ross asks, how can you help someone get off of buprenorphine?
Great question. Just like other opioids, it's actually easier to get off of buprenorphine than it is off of hydrocodone, because remember hydrocodone is like a roller coaster. And that roller coaster is very hard to step off. You don't want to step off a roller coaster. The frequent cycle withdrawals makes it very difficult. So actually getting on that merry-go-round of that chemical stability of buprenorphine helps to facilitate getting off of the opioids. Once you're on that chemically stable merry-go-round, then tapering off of buprenorphine can occur. And it has to occur slowly. It has to occur over months and months of period of time. Now, some patients, once they get down to 1 or 2 milligrams a day, have a real difficult time getting off. For whatever reason, it might be the painful condition, it might be something else. So some of the patients that I've been seeing have been on a low dose for a number of years. And so everybody's a little bit different, but you have to go slow. And you have to maybe neutralize the nervous system with other non-opioids to help. So now that we've improved health,
Oh, Dr. Lasich,
Oh,
I
yes.
apologize for interrupting. We do have a couple more questions if you
Okay.
want to take them now.
Okay.
So one is a quick one. They're asking for a repeat of the name of the nutrition conference.
Oh, yeah, that's Healthy Kitchens, Healthy Lives. Harvard puts that on every year. It's fabulous.
Great, and we will send that out in the link. And another question coming in, what is your preferred vitamin D range for a patient?
Yeah, I prefer people to get close to 60, 40 to 60 is great. 30 is too low, but to be honest, most people are below 30. They're actually therapeutic. They're in the 20s. And like I say, there's some people that are walking around with single digit. In terms of supplement, I consider maintenance to be 2,000 units a day. I consider 5,000 units a day or that 50,000 units a week to be your prescription if you're trying to build somebody up. Great questions. All right, so we've improved health, we've strengthened the core, we've evaluated the pain, we've neutralized the nervous system, but we need to go one step further. We need to talk about velocity. Remember, Bravo has V in it, and the person was asking about how do you get off of buprenorphine? Well, now is the time to think about getting off the opioid or tapering the dose, because you've neutralized the nervous system, you've improved the core strength, you've improved health. So patients are already feeling maybe a little bit better. So then is a great time to start introducing a slow taper. And the most common mistake is to go too fast. I go 10% every month, or maybe every 2 months. You can do a turtle taper and go 10% every 3 months. But the point is you're starting to go down. You're going down slowly. You can take breaks, but don't go backwards. Don't go back to a previous dose. Validate that it is difficult. Sometimes you'll have a temporary increase in pain as your body resets. There might be some withdrawal symptoms initially. If there's too much withdrawal symptoms, take a smaller step. You know, this smaller the step, the easier it is, baby steps. And then you can use other medications to help lessen withdrawal symptoms, such as gabapentin. So now is the time to introduce the taper, that you've done these other things when someone has a painful condition. But even after we've done all that, sometimes we have to have even more conversations with our patients because we want to ease suffering. So what is the difference between pain and suffering? You think about that. What is the difference between pain and suffering? Pain is a physiologic experience. Suffering is a perception. Suffering is the stinking thinking. It's the way we think about time, threats, meanings, and circumstances. It's the stories in our head. It's the perception about the divorce that happened 10 years ago, the accident that happened 15 years ago, the death that just happened last year. It's the way we are thinking about these circumstances. That's where suffering is coming from. And how do we ease suffering? How do we want to ease suffering in each other? First, I like to try to help people anchor into the moment. People use the past as a source of comparison. Doc, I used to be able to garden all day long 10 years ago. Or they're using the future as a source of worry. Doc, I do not want to end up in a wheelchair like my grandmother. These are sources of suffering. So anchoring into the moment requires two questions. The first question is, are you aware? Are you aware of your surroundings right now? The room that you're in, the air circulation in the room, the feeling of the feet touching the floor. Are you aware? And what are you aware of? Are you aware of the interconnection that we are all sharing here now on Zoom or in this world? Anchoring into the present moment is the key to easing suffering. is the key to unlocking happiness in someone's life. And I want to reference Eckhart Tolle. He's a wonderful teacher in how to be present, how to be aware. We need to help patients develop hobbies, outlets for frustration. I had a patient who had been in a terrible accident. He couldn't ski anymore. He couldn't camp anymore. He lost a lot of his hobbies. But one day he came in and he was smiling, and I said, what changed? And he says, Doc, I learned how to fly remote control helicopters. And I'm like, great. What a great outlet for someone that was not able to do things that he used to be able to do in the past. He wasn't using the past as a source of comparison. He was propelling himself into a future of new things that he could do. Reframe the story of I was in this accident and I wasn't at fault, and that victim mentality can really get someone stuck in a place of suffering. Reframe it into a story of survivorship. Look at how far you've come. Look at what you've survived. You're here right now getting help. That is your strength. You have survived what you have, and you're sitting here, and this is your strength. And being present for each of us, for our patients and for each other, getting out from behind the computer screens or the devices, and looking each other in the eyes and being present with each other. That helps to ease suffering. But really, in order to ease suffering, we also need to be able to come alongside each other with cultural humility, which is a lifelong commitment to self-evaluation, to redressing the power imbalances between physician-patient dynamics, to developing mutual beneficial, non-paternalistic partnerships with each other and within our community. That's cultural humility. But even easing suffering isn't enough. Sometimes we have to help our patients to embrace suffering, because there is glory in the suffering. Suffering produces perseverance, perseverance produces character, and character produces hope. So suffering can be a doorway to spiritual transformation, just like pain is a doorway to health transformation. And sometimes suffering is a doorway to spiritual transformation, and oftentimes it take 12 steps. So how do we solve both the epidemic of chronic pain and opioid overdose deaths, opioid use disorder? We ask for Bravo to help us safely decrease opioid dosage, carefully broaching the subject of a taper, analyzing the risks and the benefits, recognizing that addiction happens and that it's different than physical dependence, going slowly after we've explored other treatments. And those other treatments include, after evaluating the pain, you want to neutralize the nervous system, you want to strengthen the core, you want to open up a conversation about unrealistic expectations, you want to help to restore health in powerful ways that last a lifetime, and you want to help them to ease or embrace suffering. Our main goal is to create a more deeply satisfying life and restore hope. Go out and be the hope with this information. Any questions?
Thank you, Dr. Lasich. That was wonderful. I do see that a question has come in, and we'll also cue folks to type their questions in the question and answer, as well as raise their hand, and we can unmute them so they can pose their question. An anonymous attendee asks, how can you manage presence? So what you talked about, being present with your patients during COVID and social distancing.
Mm-hmm. So managing presence is using all your senses in the moment where you're at. Using all your senses, your smell, your sight, the touch, and really being present with whoever you're with, and also being present with yourself, and maybe even your higher power. I'm not an expert like Eckhart Tolle, but I can attest that slowing down and not getting stuck in our stories, in our thinking, and our thoughts can be very powerful. Lately, I've been recommending a smartphone app called Calm, which has guided meditation exercises to help people become more present and to provoke the natural relaxation response that's available in each of us. So that's a great app. There are other ways to develop presence of mind, not only through meditation, but biofeedback. But yeah, it's been a difficult year for everybody. But in that challenge, it's also helping us to grow into more awareness.
Great, thank you, Dr. Lasich. We've had someone ask to address the spinal cord stimulator question. So can you discuss spinal cord stimulators? And then I have a couple other questions coming in after that. Yeah.
So we're going to move on to some case discussions, and one of the cases is a woman that has a spinal cord stimulator. That technology has improved over the years. Initially, it was only beneficial for people that had extremity pain. Now it's improved to include more torso pain. I really consider it kind of a last resort because you're putting something in your body, and that something can go wrong, not just with the surgery and the risk of infections, but also the device can stop working. And the example we have later today is a woman that has a device that's not working well, and she's having a hard time getting it replaced. So I think it's a viable option. Typically, someone will have a trial before the permanent implant is in place. So discussing this with your provider carefully, making sure that you've explored all other options that may have less inherent risk before moving forward with it.
Great, thank you, Dr. Lasich.
Mm-hmm.
Dr. Wakil asks or states and asks, I have had more than one patient who I've completely gotten off of opioids who states that they have less pain now that they're off the meds than they had when they were taking them. Is there any way to predict which patients will have this outcome?
Yeah, and I've seen the same as well. And that is usually an indication that the person was experiencing opioid-induced hyperalgesia. And I had one such patient that I'll talk about, and she had been on hydrocodone for a number of years and also a small amount of alprazolam. And when I saw her, I said, you know, what I really need to achieve right now is chemical stability for your brain. So we need to convert you over from hydrocodone to buprenorphine. And immediately when I got her onto buprenorphine, she experienced a sudden decrease in her pain. And that to me predicts that, okay, we're primarily dealing with opioid-induced hyperalgesia. I bet we're going to be able to taper her off. And sure enough, over a period of time, I was able to taper off the opioid, the buprenorphine. So that was a predictor that conversion from the short-acting opioid to the buprenorphine product, almost eliminating the pain, that you're able to achieve that. So it's really, if you're able to identify someone that most likely is experiencing opioid-induced hyperalgesia more than anything else, then you're going to have success. The other thing I'll say about that is typically the patients will experience a lot of end of dose failure. So they're getting a lot of pain right before it's time to dose, or they're getting a lot of pain right in the morning time because the last dose has completely worn off. And so those are predictors as well.
Great, thank you. And as for now, I'm seeing that's the end of our current batch of questions.
Great. Okay, so we have some cases to discuss. And the first case is an 83-year-old man with a right BKA with phantom pain, comes to your facility after being in the hospital with alcohol withdrawals associated with a seizure. He spent a week in the hospital for the management of the alcohol withdrawals. And then the hospital referred him to you because he's also using morphine and hydrocodone. But patient reports that the pain is still poorly controlled, which is why he started using alcohol in the first place. His wife is very concerned because he's falling frequently at the house. He's not sleeping well due to discomfort. Wife says he's just not the same since he lost his leg. He used to love to go out, but no longer has interest in doing anything. So I want to first start with alcohol use disorder, and that's why I have this case in it. We have seen an exponential increase in alcohol use disorder this year with COVID and people being sheltered in place. And it's commonly seen in someone that is having a painful experience. So we're monitoring it for alcohol use frequently. In our contracts with patients for controlled substances, we state that we are not to use alcohol when using controlled substances. So this patient, he started using alcohol supposedly because his pain was poorly controlled, despite the use of morphine and hydrocodone. So how would you start to broach the topic or open up the conversation with this patient? Anybody want to take a stab at that? This is a time for you to have some interaction.
I'll just remind folks that if they raise their hand, we will invite them to unmute themselves so we can have some back and forth.
Yeah. So I think with broaching the topic for this individual, I would start with safety first. Obviously, the use of alcohol can be dangerous, and he experienced a seizure. And so I want to establish the fact that he is no longer using alcohol since being out of the hospital. I want to establish his sobriety and also the importance of not using the alcohol, having the conversation about the danger of using alcohol with the opioid. So establishing the safety first. I want to see if he's suicidal. Again, the use of alcohol and opioids might be a sign that somebody is suicidal, and you want to see if they're having any suicidal ideations. So you want to establish a safety conversation first with the patient. Anybody have any other suggestions?
So I am seeing one for our hand raised from Lisa Overholt. And Lisa, I'm gonna allow you to talk, and you should be able to unmute yourself and talk.
Okay, so one of the things that comes to my mind because of dealing with a family member who has had, actually several family members who have had amputations, and understanding that there's a lot of embarrassment with that goes with that, whether it's right, wrong, or indifferent. I would want to find out more about when the alcohol's drinking started to become so big. Was it after the amputation?
Mhm.
Because a lot of times it's the symptoms of what causes the drinking. It's the symptom of maybe he lost his leg and he's embarrassed and he can't handle the fact that he's no longer has a leg.
Yeah.
And which is why he falls and he forgets that he doesn't have a leg. So that's kind of where I would approach it from.
Mhm. Yeah. Yeah, I love the fact that you come alongside him with empathy and cultural humility, recognizing that that amputation is a source of stigma
Mhm.
and shame. And that can definitely be a root of depression or suicidality that is driving the chemical use as a form of coping. And maybe offering him behavioral health or peer support. You mentioned the falling. That's another safety item that I would address. Falls lead to hospitalizations. So my training is in physical medicine and rehabilitation. So when I see an amputee and they're having difficulty with their gait, I want to look at their prosthesis. Is it fitting well? When is the last time you saw the prosthetist? And is there pain associated with wearing a prosthesis?
Right.
Is he in a wheelchair? Does he need an electric mobility device? So looking at ways to improve his function. If you're improving his function in those ways, it helps to get to the root of the shame, the stigma, and the depression.
My family member actually, because he did use drugs, would forget that he had his leg amputated and he'd try to stand up and he would fall over.
Mm.
And it would be like, you need to use your crutches, because he was allergic to his prosthetic. He
Mhm.
tried 3 different types and kept swelling up, and
Yeah.
so he was always on crutches. But he would forget sometimes, or he would try to go down the stairs and he would catapult, so to speak. And yeah, it was really interesting to watch.
Yeah. And with amputations, we have a painful condition of phantom pain, a form of neuropathic pain. So I want to talk a little bit about treatment, going back to our principle of neutralizing the nervous system. The one medication that can be very, very helpful in this situation is gabapentin. Gabapentin is used for the treatment of neuropathic pain, but also the treatment of alcohol use disorder. So there was a study a number of years ago in JAMA that was published about gabapentin for the maintenance of sobriety. So gabapentin is known to help people maintain their sobriety that have alcohol use disorder, typically in the range of 600 3 times a day to 900 3 times a day. So for this gentleman, I would probably start him on 300 milligrams, maybe even just at bedtime, see how he responds to it, see how he reacts to it, and then try to push the dose, not only for the painful condition, but also for helping him maintain his sobriety. Gabapentin can also be used for outpatient detox for alcohol use disorder in someone that is not prone to seizures. So I wanted to bring that up as well. In regards to alcohol use disorder, we also prescribe medications to help with cravings. And those 2 medications of acamprosate and naltrexone are used to curb cravings for alcohol use disorder. So again, coming alongside this patient, broaching the topics around safety, around possibility of feeling shame or stigma, and having that just open conversation with him and his wife, and establishing some safety goals, some functional goals. Any
Dr.
other? Yeah.
I'm seeing that Dr. Wakil has his hand raised, so I'm going to allow you to unmute yourself.
Yes. Well, this patient has had an alcohol problem for a while. If it took 1 week in the hospital to deal with the management of his withdrawals,
Sure.
I think the first thing I would do when I saw him, since he's been referred to me for the first time, is I would tell him, I'm not here to judge you. That's for the courts and for other people. I just need to know. And the first question I would ask him is, how are your cravings?
Mm-hmm.
He's only been out of the hospital, probably less than a week.
Mm-hmm.
And unless I know what I'm dealing with, I don't know that I can really help him until I find out exactly where, what his.
Yeah. Yeah. Or if he's back to using alcohol already, you have to evaluate if he's currently using, what his cravings are like. But yes, this person has been using alcohol for a while. If they've already had seizure and it took a week in the hospital. Yeah. So how would you go about addressing the opioids that this patient is on?
Well, you have to tell them that the combination of the two increases the probability of respiratory depression, that he's playing with fire.
Mm-hmm.
And he's got to, I would do my best to make him understand that this is no longer I mean, he can't take this lightly. This is something that has to be looked at very seriously, because he could go to sleep and never wake up.
Right.
And I'd want to know is, as you mentioned before, is depression an element of what's going on here? Does he feel like his life is this his way? Is he self-medicating because of his depression? Does this become a dual diagnostic situation?
Yeah.
Yeah. No,
Yeah.
This is a tough one.
Yeah. And you mentioned respiratory depression. Thank you for bringing that up. This gentleman is at high risk for respiratory depression because of the use of the opioids and also the alcohol, of course. And in order to help reduce his risk of that, I would propose to try to convert him over to buprenorphine, because that is going to provide less risk of respiratory depression, and also help to provide more chemical stability than what he's getting even from the extended release morphine, and most particularly from the hydrocodone. Buprenorphine can be very useful for the treatment of phantom pain, and it's sometimes a first-line drug for the treatment of phantom pain.
Thank you, Dr. Lasich.
Yeah. Any other comments before we move on to our next case? This is just one example of how opioids and alcohol use can go awry. Great. So the next case is opioids and benzodiazepines. So this is a 53-year-old woman with lumbar pain following a lumbar discectomy, laminectomy, and she's presenting to you because the pain is getting worse and she wants to establish care. She's currently using hydrocodone around the clock, 6 a day, and she's been taking it for over 5 years. 2 years ago, she began taking alprazolam, 0.5 milligram, 3 times a day for anxiety. That was prescribed by her previous primary provider. And now she is also using zolpidem, 10 milligrams at bedtime. Her prescription drug monitoring report shows that hydrocodone is frequently filled a week early. Her urine drug test is consistent, except there was a positive test for oxazepam. When she was questioned, she admits to using her friend's diazepam when she ran short of her medications. Today, her pain is 9 out of 10, and she's feeling depressed. This is a very common scenario. Why is she experiencing increasing pain, anxiety, and insomnia? Where is that coming from? Any ideas? This is a very common timeline that is seen. It's a trend. This is very common with around-the-clock hydrocodone use. The hydrocodone is really meant for acute pain for a temporary period of time. When it's taken around the clock, every 4 hours, 6 a day, 5 years, that is a roller coaster ride that we discussed earlier. The short-acting nature of hydrocodone causes a frequent cycle of withdrawals, and that sensitizes the nervous system. Every time that medication starts to wear off, that triggers the brain to start the withdrawal cycle, and that can cause an increased pain, that causes anxiety, that causes difficulty sleeping. So a well-meaning prescriber, when hearing that, oh, you're having anxiety, well, let me give you some alprazolam to help take the edge off. Maybe she was having some situations around that as well, but very common to see hydrocodone causing anxiety, and then that being chased by benzodiazepine, followed by chasing the insomnia with zolpidem. And so a patient is getting what they want, medications to treat these symptoms, but nobody is recognizing that the hydrocodone is the root of the cause, the root of the problem. And so this is a patient that would be a great example of when buprenorphine can help. Buprenorphine is not just a medication used for opioid use disorder. She may have opioid use disorder. We can't really tell, but we do know she has opioid dependency, and that is what we need to address. Any questions? What types of questions would you want to ask her about her health? This is lumbar pain, a 50-year-old woman. How would you evaluate that? What types of questions do you want to ask her about her health? So of course, we're going to be asking about her smoking habits, her exercise habits, but I also like to ask them, tell me about your diet habits. Tell me what a typical meal is. A patient the other day was telling me about her typical meals of cereal in the morning, sandwich midday, and then some type of meat with potatoes at bedtime. And that was my opportunity to introduce the concept of an anti-inflammatory diet. This particular person, she's probably on an anti-inflammatory medication, and she's probably been taking it for the same amount of time period that she's been taking hydrocodone. So you want to address the painful condition from a different direction, not just addressing the opioid, but also using pain as that doorway to health transformation. What other things would you like to address with this patient?
So I see that anonymous attendee wrote in the question and answer, I would want to know what the patient's priorities are first.
Sure. Maybe this patient's priority is getting to the point where she can walk her dog. Maybe it's getting to the point where she can play with her grandchildren. So some of those priorities are functional goals. What are your functional goals? And we can always ask the question, what are you able to do now with the use of hydrocodone that you're not able to do without it? Maybe she's working a full-time job as a caregiver, or maybe she's on her feet all day long. So you want to establish what her functional goals are.
Let's see. Thank you, Dr. Lasich. I also see that Tracy posed, does she see a pain management care? Maybe that's care provider. Does she have a therapist to help her cope?
Mm-hmm. Sure. She might be in a place of suffering. Maybe that lumbar pain was caused by or started with a vehicle accident. It could have been a horrific vehicle accident with a fatality. Trauma it's so prevalent, and asking about sources of trauma can be extremely important. And then getting back to that sources of suffering, what are outlets for frustration? What is she worried about? What is she perseverating about in her past? Asking her to consider behavioral health, or if she's in some type of other support group. So these are all excellent questions to address the suffering, to address potential fears and anxiety, and also to discuss functional goals. What do you think about the benzodiazepine? What's going to happen to that? She's using the alprazolam 3 times a day, so she has some dependency to the benzodiazepine. How do we want to address that? It's something that we're going to have to address, not just the opioid.
Dr. Lasich, perhaps as we're waiting for folks to respond to that, I did have a late question come in from an attendee.
Mm-hmm.
Kathleen asks, my question would be, does this patient have the ability to afford a special diet? This is a problem with patients with a fixed income. What would your suggestion be for this?
Yeah, and that's a common concern about cost of a special diet. So I'm going to give you another example about a simple substitution. So everybody seems to like spaghetti, right? With the spaghetti noodles, but the noodles have a high glycemic index. So a simple substitution for that is in a little known, kind of an ugly little squash called a spaghetti squash. It's yellow. It's very inexpensive, but it is a substitution for the actual noodles. Simply by putting that spaghetti squash in a microwave or oven and allowing it to cook, and then scraping out the contents, which literally look like spaghetti noodles, and using that instead of the noodles to put the marinara sauce on. That's a simple substitution, and it doesn't cost a lot. Just look at other countries that are not considered wealthy, yet they have very healthy diets because they're living off the land, but also, using dried beans, for example, or brown rice, or lots of fruits and vegetables that are available to them as well. So cost, yes, it can be a barrier if we're not also teaching food preparation techniques, but also cost is perceived as a barrier, but what's more of a barrier is convenient. And convenient is going to fast food sometimes.
Great.
So again, I invite everybody to attend that Healthy Kitchens, Healthy Lives. It's really transformative in how you have these conversations with your patients.
Great. I'm getting lots of comments now in regard to the opioid dependency and a couple questions. So I'm going to do my best to go through and summarize them. So,
okay.
How would you address the dependency? Raina wrote, make sure they have Narcan. Dr. Block wrote, without motivation, it would be difficult without direct cognitive behavioral therapy. I would only choose to treat her if she'd agree to this. And then there was some follow-up regarding alternative meds and prescription substitutions aside. This patient might need regular daily psychological support to turn this pattern around. Otherwise, she'll be suffering. I'd be straightforward with her that her use pattern and self-prescribing are a problem. Dr. Darwin mentioned that she might be getting some rebound anxiety from short-acting Alazapram. Sorry if I butchered that. Dr. Wakil said I'd switch her to a long-acting benzo. And there was a little follow-up from Dr. Block and a few more items. You want me to pause there?
Yeah, so let's pause.
Okay.
So the rebound anxiety, I love that was brought up, because yes, alprazolam is a short-acting benzodiazepine. And just like I encourage you to consider putting this person on buprenorphine for chemical stability, because that from a short-acting to a long-acting opioid, you can also consider that for alprazolam to convert her from the short-acting benzodiazepine to a long-acting benzodiazepine like diazepam or clonazepam. Now, I propose that once you put this person on buprenorphine, that she'll experience more chemical stability and less frequent cycle withdrawals with the opioid. So that in and of itself will reduce some of the anxiety, which will help you. You may still have to convert her over to diazepam or clonazepam, but it'll be much easier because some of her anxiety is already controlled by the long-acting buprenorphine. And then once you decide that she's chemically stable with a long-acting opioid and a long-acting benzodiazepine, then you can start a taper. I usually just taper one. I'll start with the opioids sometimes first, or sometimes I'll start with the benzodiazepine, but usually not both at the same time. And that's how you, again, start with chemical stability first, and then you can start the taper. It makes the taper a lot easier.
Great, thank you. Sorry to give you a fire hose of questions to respond to.
Any other questions? We have one more case to discuss.
Yeah, there's one more question on this and one raised hand. Maybe we could get to both briefly. Someone asked, they stated, to me, the benzodiazepine dependency is a more pressing issue. Is gabapentin an option there?
Gabapentin is an option if you feel like the patient is experiencing withdrawals to help to stop the stress reaction in the brain. If you're converting her from hydrocodone to buprenorphine, you can use gabapentin for the transition. You can use gabapentin to help with managing anxiety, but also you can use gabapentin to help with transition from alprazolam to diazepam, for example. So gabapentin is very useful for those transition periods to help stabilize and block that stress reaction in the brain.
Great, thank you. And
And also useful for the pain, she may have a radicular pain into her leg, for example, a neuropathic pain. And if she doesn't tolerate the gabapentin, don't forget your alternatives, such as zonisamide.
Great, thank you. And the raised hand belongs to Jane. So Jane, we'll have you unmute yourself and pose your comment or question.
Hi, Jane.
Hi, can you hear me? This is actually Mary Nickel.
Okay, Mary.
Hi. I just want to say I so appreciate your use of motivational interviewing and just approaching and bringing up diet as a key factor as well. And so mine was more of a comment around what would you ask about health, and I would really want to know what this woman does for fun, or what she used to do for fun, and who's in her support team, and how can we really add to that for her and maybe lessen her overall stress by allowing a little bit more fun in her life.
Mm-hmm. Great. Absolutely. You want to ask them what they do to experience joy in their life. You want to ask them what they do to decompress and to relieve stress in their life. And you mentioned support systems. What types of support systems is this woman experiencing in her life or not experiencing in her life? These are all doorways to health transformation, and health is just not about physical health. It's also about emotional and mental health. You know, the concept of resiliency. What does she think about resiliency in her life? Is she feeling resilient and able to bounce back? One important aspect of resiliency and joy is being curious. What is she curious about? What does she want to explore in her life? What new things does she want to learn? That can provoke a source of joy and of resiliency.
Thank you so much.
Thank you, Jane, or Mary. And any other questions?
It looks like we're good to move on. And just a quick time check, but we'll have you go right up until 1:55, Dr. Lasich. I know we have one more case left.
Okay, and it's a doozy, but we'll make it fast. All right, this is a case of high MMEs and concurrent use of benzodiazepine. Yikes, right? Now we've all inherited the yike patients, the patients that are on super high MMEs and maybe even both benzodiazepines and opioids. And okay, what do you do in your first visit? So here's a 57-year-old woman. She just moved to the area. She injured her ankle 15 years ago, developed complex regional pain syndrome. She's using 70 milligrams a day of methadone, 3 a day of oxycodone product, 1 milligram of clonazepam a day. She has the spinal cord stimulator, but it's poorly functioning. She's tried duloxetine, which didn't help. She has trouble getting pregabalin through her insurance. She's in a wheelchair for community distances, uses a walker for household distances. She's feeling anxious, depressed. Left leg is atrophied with skin discoloration. She has extreme allodynia with light touch. That's pain with normally non-painful stimuli. So yikes, right? What do you do in your first appointment with her? Where do you start? Right, you start with Bravo and ENCORE. You start with broaching the subjects.
Okay, so I see we have a hand raised from Michael. And Michael, I'm going to allow you to talk and ask you to unmute yourself.
Go, Michael.
Yeah, I'd start off with motivated interview to get her trust, you know, get to know her a little bit better, so that you do have that trust, because without that trust,
she's out the door.
Yeah, exactly. She's out the door. She's not going to take your suggestions. She's not going to listen to you. So that's how I'd start off. And that's it.
Yeah, coming alongside her, you know, even that first appointment, just getting to know her. You don't have to do anything that first appointment. She's used to where she's at. And you just want to come alongside her, meet her where she's at. You can start to plant seeds. You know, I see that the pregabalin you were having trouble with, was it helpful for you? What dose were you previously on? Explore other medications that she had been on in the past. Just the exploration and discovery period right now, so that you can just evaluate what your options are. Anybody else want to jump in to the deep end?
I'm seeing a raised hand from Juliet, and Juliet, I'm gonna allow you to talk and ask you to unmute yourself.
Okay.
Great, thank you. Hi, I would empathize with the frustration of the long-standing injury, and also ask the question, tell me what you know about the combination of opiates and benzodiazepines. And then depending on what she says, I would ask if it would be okay to fill in some potential gaps that she might have about that.
Yeah, that's a great way to approach it. You know, see where she's at in her knowledge about the risks and the benefits. And, you know, she may not be aware that, hey, with, you know, methadone, we need to get a yearly EKG. She may not be aware of that. Yeah, so all of these are great suggestions. And I'll tell you where I went with this patient. This is an actual patient of mine. I recognized that she was feeling depressed and anxious, and those negative emotions can amplify painful conditions. So I first wanted to address the source of negative emotions, which leads to suffering. And so I started her on the Prozac. The duloxetine she had done before, and it wasn't helpful. And we started her on the Prozac. We got the EKG, and then I connected her with the rep for the spinal cord stimulator. And then we, you know, discussed what her goals are and her expectations are, and what she understands about her current situation. Next, the pregabalin. I was able to document that she has a neuropathic pain, and, you know, starting her on a low dose of the pregabalin. Once I was able to start her on a low dose of the pregabalin, and establishing some trust with her, and, you know, we both had concerns about the risks of the methadone, the oxycodone, and the clonazepam. She was willing to go down to 65 milligrams of the methadone as the first step. Think about it, 65 milligrams, it seems like a drop in the bucket, but psychologically that's a big step. But I knew it was doable for her, and she wouldn't necessarily feel that effect. It's a baby step. And that helps to build their confidence in you as a practitioner, and in the fact that they can do this, they can move the needle in that direction. Any other comments?
Not at this juncture, it looks like.
Okay. All right. So 2 years later, she is on 60 milligrams a day of methadone. She's still taking the oxycodone product with the Prozac that she's on 40 milligrams a day. and also the Lyrica, she was able to reduce her use of the clonazepam. And so she's no longer using the clonazepam. The spinal cord stimulator, the product was discontinued and had to switch to a new vendor. So we had to establish connection with the new vendor. Her prescription drug monitoring has been consistent. The urine drug test, prescription drug monitoring program, the EKG QT interval is acceptable. To me, acceptable is below 430, preferably below 400. Her vitamin D level is 41. Her activities are still poorly tolerated. Her sleep is disrupted due to pain. So where can we go?
Sorry about that. I have a comment from Irina. Irina, I'm going to allow you to talk and ask you to unmute yourself.
Okay.
Hi, doctor. Thank you. I seem to recall you saying that you would prefer the vitamin D at a higher level. So that's
Right.
one thing that I would maybe address as taking a supplement. And the other thing I wanted to go back to is her depression and anxiety, and maybe getting her connected with a counselor, and then maybe getting her connected with a wellness coach to focus on increasing her activity if that's something, goals that she wants to set, as well as maybe increasing or getting better sleep to for that all-around approach.
Right, right. Absolutely. Getting the rest of your team members involved. So a behavioral health therapist, and discussing nutrition, of course, maybe connecting her with a nutritional consultant, a wellness coach, like you said. Establishing, her activities are poorly tolerated. Maybe she needs to be in some physical therapy. Remember, she's using a walker and a wheelchair. Maybe we can set some functional goals that we can help her achieve with physical therapy. Her sleep is disrupted due to pain, and that's going to be an amplifier of her painful condition if she's not sleeping well. So looking at maybe optimizing some of her medications, the Prozac dose, and even the Lyrica dose. I start Lyrica at 50 milligrams a day, and then increasing that as tolerated, and that to help support sleep, help to reduce pain, and then also help to support your opioid taper. She's on 60 milligrams a day, which may not be in someone's comfort level. So eventually you're going to maybe want to have, additional conversations about dropping down again. And I also want to discuss about respiratory depression in patients like this. A number of us are getting what we call the oxywalks. We're getting nighttime oximeter and capnography to evaluate for respiratory depression. That evaluation can also enter in your discussion about risks as you motivate her to continue a taper for her own safety. Any other questions or comments? We'll be closing our session in a couple minutes. This is a final opportunity to throw out any questions, not necessarily about this case, but anything that's on your mind. You can also ask questions later. I think they're going to give you access to getting my email so that I can answer your questions at a later time.
So one additional comment, and I believe this is in regards to how to proceed now in the Q&A. Dr. Mings writes buprenorphine, ?
Yes, particularly if you discover that she does have respiratory depression. She's on 60 milligrams a day of methadone, which is kind of my threshold of when I will consider converting her to buprenorphine. I don't like to convert to buprenorphine if they're on a higher dose of methadone. If any of you have done that conversion, it can be rather tricky. For her, what I would do is have her stop the methadone, and I would probably raise her oxycodone product to taking 2 tablets 3 times a day during that time period where she's off the methadone as a bridge. And then I would have her stop the oxycodone 24 hours prior to starting the buprenorphine. And I would probably have her off that methadone for 72 hours.
Great. And I think we have we're at time, but maybe one final question. Juliet asks, what is the typical response from patients dealing with chronic pain when you mention an anti-inflammatory diet? Are they open to it?
Oh, absolutely. You know, patients, they're in a place where they're willing to try anything sometimes. And I tell them it's not about your weight. It's really about what's happening chemically inside you. And the example I give is most of us have vehicles. And what happens when you put bad gas in a vehicle? Well, it doesn't run very well. And if we're putting a lot of simple carbs and sugars into our body, they're not going to run very well. And it causes, you know, a condition of pro-inflammatory state, metabolic syndrome, and pain. And so we hear that, and most commonly the response is, how come nobody's told me about this? Because here they are, they've been trying every other medication under the sun, they've tried injections, physical therapy, but nobody's talking to them something as simple as diet. Because it's not, if you come at it as diet, like you need to lose weight in that judgment, you're going to lose them. But this is about what's chemically happening inside them, working with your body so it can control inflammation naturally.
Great, thank you, Dr. Lasich. This has been just a really wonderful session. I'll turn it back to Rosemary. I think there may have been a question or two still open, and I would just encourage folks to write that into the Q&A, and perhaps Dr. Lasich can type a response there.
Yeah, thank you very much. I appreciate the opportunity. And remember, just go out there and be the hope. Thank you for joining us.
Thank you, Dr. Lasich, for providing such rich content and information that we can all take away, whether we are clinicians or support staff or whomever. I think that a lot of that was really tangible for all of us. So now we're going to shift a bit and hear from 2 folks a little closer to home. From Kamau, Dr. Eva Smith and Dr. Dagim Taddesse, and hear about the work that they are doing out at Kamau in Hoopa and how they are really bending the curve for prescribing opioids. So I hand it over to you.
All right. Thank you for giving us this opportunity. My name is Dagim Taddesse. I'm a pharmacy director at Kamau Medical Center, and I'm also advanced practitioner plus a diabetes specialist. So, and Dr. Smith is a medical director, and she is gonna present after me. All right, next. All right. So today we are gonna present you the safe prescribing practice and the medication assistance program that is happening in our organization, and we're gonna show you how we are doing it. Probably you might learn a little bit from our experience. Okay, so these are the objectives that would be discussed. We're gonna illustrate the decreased in controlled substance prescriptions from 2016 to 2019 at Kamau Medical Center. The reason why I do this is because I was hired as a pharmacy director in 2017. So I just want to use 2016 as a reference and see what I've been doing this past almost 4 years. So I did include 2020 because it's not, the year is not in yet. So I did reflect that 4 years. And also the other thing would be, understand strategy used to address this opioid crisis in HUPA. And Dr. Smith is gonna describe the evolution of this Chemo Medical Center medication assisting program later on. So with respect to the following presentations, neither Dr. Smith nor me don't have any actual or potential conflicts of interest in relation to this program or presentations, and no relevant direct or indirect relationship to disclose. So this is the front entrance of Chemo Medical Center. Chemo Medical Center is basically a joint commission accredited primary medical home. So it looks like this, okay? Okay, so this is the Chemo Medical Center 2016 to 2019 controlled substance reduction report. So this report was presented to governing board of Chemo Medical Center, and also it was also presented to the coalition meeting. So basically, I highlighted with different colors in order to see, just different classifications. As you know, narcotics has different class. So the C2, class 2 being more restricted, class 3, class 4, and class 5. So basically, I started in the data starts in 2016. So the decrease starts in 2017. Since I was hired in 2017, that's what I'm trying to show you here. So let's start with C2. So in 2016, before I was hired, there was 6,895 prescription was prescribed. That's related to close to 500,000 pills of C2, as oxycodone, methadone, and all those kind of things. And then in 2017, we were able to decrease the prescription to 6,568. It's kind of few prescription number decrease, but then the amount of pills decrease is huge, which is to 414,752, close to 81,000 pills of C2, as methadone, oxycodone, Percocet, all those kind of things. And then in 2018, you can see also the prescription decreased to 6,184. That relates to pill decreased to 387,795. So basically, that is also close to 27,000 decrease. And 2019, you can see prescription decrease close to 1,196, a total of 64,000, close to 65,000 decrease for C2. So let's see it from here. So basically, if you see from the total decrease of from 2016 to 2019, close to 2,000 prescription decrease, that relate to 172,368 pills of decrease. That's a huge slash on C2 alone. But then we have done that for C3, C4, and C5. On C3, we've been decreasing that in 2016, in 2017, and 2018. You can see a decrease in there. But in 2018, May of 2018, we started MAT program, medication assisted program. Suboxone, as you know, is a C3. So due to that, you can see a little increase since 2018. So from 13,684 to 15,453. So for the total amount, if you see for C3, because of this MAT program, instead of decrease, we are increasing. so Suboxone program. So the total, if you see for C3, 798 prescription increase, which relates to 13,010 pills of increase, but this is due to the program. If you see class 4 or C4, for all of the years 2017, 2018, and 2019, it has been decreasing consistently. So for that, from 2016 to 2019, you can see that 2,129 prescription decrease, that relates to 98,555. That's also a huge slash. That's the sleeping medication like and anxiety medications. That is combining with the C2, which is very dangerous. And then C5, the same thing. We have decreased, if you see the last one from 2016 to 2019, you can see that we have decreased 356 prescriptions, which is related to 51,721. So if you add all of this, this is like more than 300,000 pills of decrease for this a small community. Basically, to give you a perspective, you know, in Hoopa, the population is around 3,500, close to that. But the prescription, as you see, is a huge number of prescription. And I was really worried about this when I was hired. And, you know, I sit down with the providers and I talk to them seriously, and we have done that. So let's go to next slide. So you can see from this slide that the red line is the pills, and then the blue bars are prescriptions. So this obviously would show you how the prescription and the pills, both of them are decreasing from 2017 to 2019, and basically it's continuing in 2022. And here I told you about the decrease of C3 until May of 2018. So May of 2018, what happened is we started MAT program, medication assistant program, so that would actually help patients. And we actually try to assist patients who are on opioid to transit to this medication assist program. Dr. Smith is going to talk about this, but this obviously would show you that the pills and the prescriptions increase due to Suboxone treatment that we have started. Again, look on C4. Obviously, the prescription and the pills are consistently decreasing, and it's continually decreasing in 2022.
Dagim, if I may, we are seeing a question come in. How many clients are in this report? And I think it was the one just previous.
How many clients? The patients in?
Yes, how many clients were reflected in the report?
So I say the population of Hoopa, so 3,500 kind of thing. So basically, but this pharmacy is not only assisting Hoopa. This is a remote pharmacy, so it's assisting the Hoopa and then the surrounding communities. So there are Witchpeak and there are Willow Creek and there are others, but the majority of the patients are on reservation. So basically, even if it's for so many of the surrounding areas, but the main part of the patient population is from the pool of 3,500 patients.
Thank you. Thank you.
Okay. All right. So again, we can see here for C5, obviously it's decreasing pretty good. The both prescription and pill numbers are decreased. So I would like to show you the pill counts and prescription number % decrease for controlled substance from 2016 to 2019. So it's a good idea to see it in person so that you know how much we have done with this. So for C2, from the previous page, I told you that it's close to 81,000. That's 16% decrease. And in prescription, it seems like it's like 5% of prescription decrease is related to 81,000 pill. You might question how we have done that. So one of the strategies that I'm going to talk about later is to find out the high-risk patients and to make sure that a necessary action has been taken. And 2018, with close to 6% of prescription decrease, there was around 7% medication decrease. And then 2019, you can see that from 19 point, close to 19% decrease, a total of 16% of pill decrease. So the main thing that I would like you to see is the date from 2016 to 2019. So we were able to decrease 35%. That is 172,368. That is 35% decrease for C2. That's a huge slash. And then the prescription amount, if you see that, is close to 28% decrease. Still, the prescription doesn't seem that decrease a lot, but the pill numbers decrease. That means the bigger amount of prescriptions has been decreased. On C3, for the first year, 2017, you can see that for the pill numbers, like 44% decrease, close to 44% decrease. And then for prescription, it's close to 48% decrease. As I told you, on May of 2018, we have started this medication assist program, my program. So then that actually able to increase, and instead of decrease, it increased both the prescription number and the pill number. That's the red one. You can see for C4 and you can see for C5, it's a very huge decrease. So the top number indicates difference of pill counts. The top percent indicates percentage difference for pill counts. Bottom number indicates difference of numbers of prescriptions, and bottom percent indicates percentage difference for prescriptions. So I did also colors. So the green color actually indicates decrease, and the red color indicates increase. Next slide. All right. So, okay, I told you numbers and percents, and how did we do it? That's the most important one. So strategies used to address this opioid crisis or opioid prescription issues in our organization is one of the things that we implemented is we used effective communication with providers and patients. I told you, we sit down with the providers. You know, the first day that I was hired here in Chemo Medical Center, I sit down with main providers and I say, you know what, we have to change. And that is what it is. And we made judgment calls before we fill the controlled substance prescription. That's also another tactics that we used. You know, when you do that, of course, patients are not going to be happy, and but we also used non-confrontational way to de-escalate situations, which comes from the agitated patients, and that's the one thing that was pretty hard for us. Working with a Native American on the reservation, basically cultural issues also important, so we take into account that cultural issues. So the cross-cultural competence has been used to address specific issues also. We express the co-liability principle to the providers and patients. You know, most of the time I bring this idea saying, you know, pharmacists are responsible for what they do, and not only a prescriber. So that this issue has been address properly and talk to the patient and talk to the providers that assist us in decreasing this opioid. Next slide. So the other strategies that we use is know your patient. Numbers sometimes doesn't matter. So you have to know your patient, you have to engage with your patient, and we don't want to be judgmental. Patients can take medication for different reasons, but at the same time, our job is to make sure that patient has been taken care of. So I always say this, patient-centered care. So why do patients take that medication, and if that's proper? So we suggest alternative treatment that is available for some patients also. And as you know, pharmacists can often be the person that coordinate care. We are in between the provider and patient. So basically, when there is a problem, we talk to a provider and we address patient issues. And one of the things that I would like to let you know is providers here are very receptive, very approachable. That assisted me to perform the job. Pharmacists are in a unique position to intervene with physicians on behalf of patients, as I told you. So constantly we talk to the providers, we address the issues and all those kind of things. So one of the things that we have to know that if pharmacists are really concerned about the prescription, you have to speak up, talk to the providers and address the issues, and also address that issues for patients. That has been the strategies that we used to decrease this medication. Next slide. So how do we do it? Consultation. Consultation is very, very important. So by the way, consultation is required by law for every new or dose change prescription. A pharmacy has to do that. So by offering consultation, you get to understand the patient problem, and you get to scan things. So it is a very good way of communicating to patients. So that's near and dear to my heart. So one of the things that I've been doing here is to offer consultation for every single individual patient, so that we can address our issues also. So when trying to engage regarding prescriptions, we use open-ended question rather than just a yes or no. Things I don't want patient to say yes or no. I want patient to explain to me why they are taking this and why that is important to them. And when they explain to you, and you can actually know why. And of course, the three big things or questions that we use is we ask patients why, what's this medication for, if they know about the medication, and how the doctor told them about it, and what the side effect is, and all those kind of things. So it's very, very important to convey to patients about everything that would be important for them. So you might also mention about opioid is not the first line treatment for pain. It might be a short term. Some of the patients, to be honest with you, has been on it for a long time, and they don't even understand why. So it's a good idea to talk to them. The other important thing that we've been doing is a shared decision making, patient, provider, and pharmacist. So sometimes when you are trying to explain to them, when you are educating patients, when you are doing all those kind of things, to be honest with you, when they understand, they would change. So that is very important. Okay, next slide. The Tishbach method is the one that we use. So this one is basically to actually, when we consult the patient to tell us back. So this is a very crucial tool in order to understand if the patient actually understand what you are trying to address. Next slide. Okay. So some of the things that is important also that we have used is red flags. the following red flags may indicate an illegal opioid prescription. If patient insists on paying cash, that's important to check everything. Or if patient or prescribers are known to pharmacy staff, or if patients or prescribers from a distance location, that is also another thing that we have to use. And prescription written for unusual quantity or combination, we check that. And then also we check for suspicious patient behavior. You know, if patients are coming to pharmacy like 2 minutes to close and they are trying to get their medication, or in a big hurry, or, you know, they'll show you signs. So we also see those signs. Okay, next slide. So the key consideration to red flag, we always do the due diligence. We check cures for even in-house prescriptions. We do constantly check that. We always verify the prescriber's DEA if it is outside prescription. We also check if the diagnosis or indication for use is in the prescription. If the diagnosis and use is not in the prescription, or if there's no indication, then we question about it. We also verify if the patient has relationship with a provider. And lastly, of course, we also try to see if the patient, you know, attempting to fill their prescription is within reasonable time frame, you know, if it's not early, or if they are not, you know, requesting this again and again. Next slide. Okay, so these are some of the challenges that we have when we are doing this. Of course, you know, when you are telling patients, I'm not gonna fill your prescription, or your medication is being decreased, you know, that agitate them. So dealing with agitated patient is a challenge for us. Sometimes it's also, as I told you, this is a remote area pharmacy, so setting a clear limit to patients' unacceptable behavior sometimes it's difficult to enforce. This is the only pharmacy, so you can't just say no all the time also. So that becomes a problem for us. Of course, communicating to patients regarding their denied controlled substance, that's a hard talk, it's a hard stuff. You tell the patient that I'm not gonna fill your prescription. The patient has been using this prescription for over 10 years, 15 years, but you decide to say, you know what, we're gonna decrease you, and ultimately we're gonna wean you off. They're not gonna like it. So that's a very big challenge for us. And sometimes also we get a verbal threat. I got a verbal threat every time. You know, even 2 weeks ago, I got a verbal threat because I told the patient that he have to, you know, do labs, and the patient wouldn't like to do labs, and he was, you know, doing that verbal threat. So we have to do some steps in order to prevent that kind of thing. But that can be also a great concern for pharmacy staff safety. I guess now Dr. Smith is gonna continue her part. Thank you, Jessica.
Thank you, Dagim. Thank you, Dr. Smith. I so appreciate the data you shared, and I do want to flag for you both that we're getting a little close in time. I don't want to rush you. What you have is so important, and there's a couple questions at the end, but I think we've got just a shorter bit of time.
Well, we should roll through, and we can modify as we need to. If you give me the 5-minute warning,
I will do.
Okay, great.
Thank you.
So I'm going to present some information about Hoopa, and for those not familiar with the area, we're about an hour and a half from Eureka, an hour from Arcata. The traditional term for this group of people in this area is called Natinaway, which means people of the place where the trails meet return. This tribe, somewhat unique to some other tribal histories around the country, is that this is their traditional territory. This was not a tribe that was relocated. Life and culture are very much linked to this part of the world, this river, this land. The remoteness in lots of ways have protected the tribe from colonization longer than most. Many cultural and traditions of the Hoopa people are very much intact and still a part of everyday lives, with prayer, world renewal, seasonal dances, medicine, and healing wells. Still very much a part of the culture here. Next slide. So our MAT program started May 2018. We started with 2 wayward physicians. We had a physician on staff who was able to prescribe at the time Suboxone first came out, but there was a hesitancy to be the only prescriber. And we're going to go into that in a little bit more detail. We currently are trying to do our inductions on Tuesdays and Thursdays by appointment, although in the beginning we were very flexible. Of somebody shows up, they're interested, we would do everything we can to juggle schedules to try to get somebody connected to services right away. We were using a holistic approach, looking at medical nursing needs of the individuals. We have access now to substance abuse counselors, which was one of the other factors to delay our being able to start. We have access to behavioral health therapists. We do try to offer an individualized treatment plan and a cultural component. Next slide. So the resources that I'm going to describe have been very important, but we also have to talk about the reality of COVID and what that has done to really complicate everybody's life, including those trying to offer opioid treatment services. We're fortunate to have a staff that cares, a staff that has been flexible. We fortunately do have funding to support sober living for men and sober living for women. We didn't always have those resources, but those have been very, very important to assist our program development. Over the time that we started, we've now increased 12-step meetings 6 to 7 days a week, although things kind of went low for a while with COVID. Zoom 12-step meetings were offered, and we are just in the past week or so trying to restart limited all the social distancing, masking requirements to offer some level of in-person 12-step meetings. We do have on-site behavioral health and AOD classes, alcohol and drug classes, but again, those had been put aside for COVID, and we tried to do more virtual work, which was challenging. This is a community where not everybody has a phone. Even if you have a phone, depending on where you live on the reservation, you may be in kind of a Dell cell area. So the connectivity isn't always great. We've done a lot of Narcan distribution and education in the community. And because of the many cultural practices that are still so very strong in this community, we do our best to integrate that. And we'll talk about that again in a little bit. Next slide. So one thing that was real obvious as we engaged taking care of these patients, I'm a family physician. I'm also addiction medicine, preventive medicine physician. But these patients all have complexities. This is not just take a pill and go to classes, but almost everyone has concurrent current issues or past histories, often linked but not exclusively linked to their prior drug histories. So juggling and trying to make sure that in the midst of everything else, you're still trying to be attentive to what are their acute and chronic medical needs. Patients obviously also have diabetes and asthma and arthritis and lots of complications with chronic pain. Lots of behavioral comorbidities with depression, PTSD, bipolar disorder, et cetera, obviously other co-occurring substance disorders. And then the social complexities that are also challenging that everybody around the country is struggling with, whether there's issues of homelessness, or maybe you have a home but there's no utility, or how do you get from one place to another because there's no public transportation and you're dependent on a family member to sometimes be able to assist with transportation. Obviously, there are legal issues, there are custody issues, there's food insecurity issues, concerns about family violence, concerns about who's in the residence. Even if you go to rehab and you're trying to come home, who's living and who's not using in your house. And then how do you support dealing with extended family needs and addressing generations of ACEs, adverse childhood events. So looking at some of the next slide, thank you. Looking at some challenges and strategies as we develop the MAT program and piggybacking some of the things that Dr. Taddesse has talked about. There's a background of long-standing community drug use. This is not new. It happens to currently be some issues of opioids, but this is a community that's had long-standing methamphetamine, certainly in this county, marijuana forever. And then of course, we cannot forget that alcohol has been for a long time, currently is, and probably unfortunately will still continue to be a challenge. Like other places we've struggled with provider turnover. We've had locums providers, and when I first got here about 23 years ago, it was very clear that it was a community that was used to having locums, that every couple of months there was a new locums in town, and so people would line up to see how they could hoodwink the poor new doctor that showed up. So finally got a grip on some of that. We do try to offer multidisciplinary pain assessment. This is going back 20 some years at a time when there was a different standard of care, very much before the more recent CDC guidelines, where we would send people to the university hospital to get a multidisciplinary pain evaluation, and they would often come back with recommendations to be on long-acting, high-dose meds. And I can recall several patients that we would send off and come back with, you need to be on more, you need to be on longer stuff. So that's part of the context of, as we talk about trying to address some of the chronic pain issues and getting away from opioids. It comes from the history of, this was a standard of care a while ago, and how do you shift that? Next slide. So in the, probably around 2005, we were quite concerned about some things happening and we were observing in the community. Part of it was drugs basically coming into the community, not coming necessarily out of our pharmacy, but we made a decision to take OxyContin long-acting off of our formulary. At the time, there was something called the Soma coma, which was people taking a combination of Soma and an opioid and being semi-comatose, and unfortunately with fatality. I understand that Soma is back, and something that they're calling the holy grail of Soma, an opioid, and a benzo. But drugs come and go, and it's a challenge. We had made a decision a while ago that locums cannot prescribe opioids, only permanent providers. In 2011, we moved into a medical home model with all patients to be impaneled. So anybody on chronic pain medication was seen by a primary provider or their teammate, and tried to limit who had access to writing scripts. Next slide. We've had pain contracts forever. When I first got here, there was a requirement that if your meds got ripped off, that you would get a police report, and then that later became a joke that anybody could go and say, oh my gosh, somebody stole my narco, or Vicodin at the time, and realize that people are just really crafty and good at playing games. In 2005, I'm talking, quite a while ago, we here at Kamau organized a pain committee with providers, pharmacists, and later on behavioral health was merged in to try to collectively, basically, as I say, put some objectivity to something that is so very subjective, with patients coming ooh, ooh, ow, ow. And so we had a pain committee meeting today with an individual that had been tapered with opioids and was quite frustrated with that. And yet it was an opportunity for not just the one patient and one provider, their continuity provider, trying to address the issue, but to have other people in the room to really hear what the patient's story and description of their history of their pain, their history of treatment of their pain, and just get some other ideas about how do you approach providing good care. And so we've had this again since 2005. I know pain committee is something that now is being promoted. Certainly is something that's evolved since the 2016 CDC guidelines, but it's something that we've been committed to for a long time and have found to be very helpful. In some circumstances, it's been clear that it's a dependence issue, and we've been able to support individuals getting into treatment. This is before we had Suboxone, which is now yet another treatment modality we have available, or recognize that there's a lot of co-occurrence of chronic pain and development of opioid dependence while treating chronic pain. And then obviously there's a lot of behavioral health overlay that also needs to be addressed. We, working with the pharmacy, have worked very diligently to not do early refills, which used to be quite a con, but we've gotten a grip on that. We had limited injectable opioids in the clinic when I first got here. People would come in regularly for, at the time, Demerol or other kind of injectable opioids, and that just doesn't happen anymore. And people know if they're in pain, maybe they can get a Toradol shot, but injectable opioids are really, really limited. Basically, if you have an acute fracture, an acute MI, and you're going out by ambulance, that's the only circumstance that we have a limited injectable opioid on campus. Next slide.
And Dr. Smith, this is just a quick 5-minute time check.
Thank you. Okay, we're going to cruise through. So the majority of our patients, but not exclusively, have partnership, which is our managed care Medi-Cal in our area. Back in probably 2014, they began giving us list of high dose, high risk patients to begin to really look at what are we doing to try to limit opioids, and what was the justification, the why question of somebody on it. And then obviously the guidelines came forward, and we continue to take those on a daily basis. Next slide. So just other programs considering doing medicated assisted treatment. You obviously need more than one provider. You got to have counseling staff. There was honestly a hesitancy of some community members for us to even start the MAT program, with a concern of, oh my gosh, you're just going to substitute more drugs, don't do it. So there was a lot of education that had to happen in order for there to be a level of acceptability to even allow our medical staff to begin the program. First script was written 5/18. We were working with a consultant who, as she said, just do it. And so she said, a patient will walk in the door, you know it's right, just do it. And that's what we did 5/18. There was a day, and I called, all the counselors were out of town, and I called them and said, I wrote my first script. I sent the script not even to our pharmacy because we didn't have it. Wrote it for an adjacent pharmacy about 12 miles away. Currently, we probably average 45 to 50 active patients at any one time, with people going off to treatment, coming back from treatment, unfortunately relapsing. But at any one time, we probably have about 45 to 50 active patients, with some people going on to sober living and relocating elsewhere. A challenge is, what is success? Next slide. So our view of success is, what are some of the variables that we can look at? Are people working? Are people in school? Is there commitment and demonstration of reconnecting with the family? What are people's involvement in the community? What are the cultural practices that people are getting re-engaged with? And a key thing is a philosophy that we want to always keep an open door and an open mind, so that people come back. Relapse happens, that's a reality. But if we continue a message of caring, and somebody relapses, if they know that our doors are open, they will come back, and they may come back embarrassed, they may come back with shame issues that we can try to help, but know that this is still a place where there is offering of hope and offering of support. Next slide. We're also fortunate that we have a CDC funded grant that really helps promote a lot of cultural wellness issues. And so next slide, I know we're limited on time. Let's do the next one. So this is our area. It's a beautiful, beautiful part of the world. And just a little thing about the traditional ways of this land. Next slide. So what does it mean to be successful? And if you look at a society that's a population of people living in an organized group with social institutions and expectations of behavior, for people to go through medication-assisted treatment, other forms of outpatient, inpatient treatment resources, and to be able to come home and participate in cultural practices, that is success. There are ceremonial dances that happen here every other year, and there were several young men in particular that were able to come sit at a table, participate in the dance ceremonies in ways that they hadn't in a really long time. And that's a part of success. There's the job issue. There's obviously being able to be a good dad, a good mom. One of the things, indicators that we look at is when we're listing our monthly visits of, okay, how many people are stay-home moms, stay-home dads, and really home and being with the kids. And right now with COVID and school and all the other challenges of life, Those are some of the successes. But for people to be able to also participate and integrate in their community with the role that they're asked to assist with, whether it's fishing or hunting or preparing meals or making ceremonial materials, that's also a part of what we consider success. So our program is relatively young, it's growing. It's very exciting to see the growth that has happened in a relatively short period of time. And we are fortunate to live in the context of a community that still is very strong in a lot of its cultural practices that people may have grown up with, but for a variety of reasons had to step away from for a while, or maybe in their circumstances never really got to grow with some of the cultural resources here and have an opportunity now at a later point in their life to integrate and to be valued as a human being in a community. I think that's it. Are there any questions? Next slide. I think that was the last one. And I think we should be on time.
Thank you, Dr. Smith, and thank you, Dr. Taddesse. I loved your beautiful framing of success at the end there. We did have a question that came in during your presentation. An attendee asks, how do we follow up to know if when we are reducing prescription opiate rates, we aren't moving people towards illicit substances? Do we track how many people simply quit going back to the doctor, ? Or how many start testing positive for illicit substances, ?
I wouldn't say that there's a formal tracking, but it is a relatively small and somewhat close community. So it's seen pretty quickly if people are back with continuity or they're out and about and on the streets, and that word gets back. But we're always trying to do outreach, and we just had another grant that was funded that gave us an extra outreach coordinator. So if the individual doesn't come back, certainly the family member is going to loop back around and say, this is what's going on. And then we look for opportunities for intervention.
Great, thank you very much.
Thank you, Dr. Smith and Dr. Dagim. That was just fantastic and just really wonderful to see all the progress and the good work that's happening in HUPA and at Kamau. I think, you know, the overwhelming message from today from both of our presenters is there is hope. Christina, Lasich said that to us, and we just heard that from Dr. Smith as well. There is hope, and with all of us continuing to do this work, we will be able to combat this ongoing epidemic. So as a reminder, your evaluations are due by the end of this week, and they will be emailed to you as well as being a part of the Zoom chat, and you can find those on our website as well. I did want to provide for you some information regarding tomorrow. We're going to have a fantastic presentation around empathy and increasing empathy in our interactions from Elizabeth Morrison and Tricia Cook. However, there is a change. If you did register for this webinar, we are going to be sending you a new link for that session. So watch your inbox and watch for that link, and we'll be communicating with all of you via email over the next 24 hours to make sure that you're able to participate in this informative session. So we'll see you tomorrow at noon via Zoom and Facebook Live. We just want to make sure that you check out our updates from the field using going to our YouTube channel and on our website. So with that, I will say thank you, and we'll see you tomorrow.